Government policy can seem remote or irrelevant, but as the pandemic has shown again and again, it matters. And as Ontario faces another state of emergency, the province's crisis triage protocols have become vitally relevant, particularly to older people and those with disabilities. Sarah Trick is an Ontario Hub's editor. She's been on this story and she joins us now from Ottawa. Welcome to the show.
Hello.
Now, just before we get started, so that everyone is on the same page, let's have a look at this. What is crisis triage? A crisis triage protocol is activated in the case of a public health emergency, such as a pandemic or natural disaster, when the demand for medical services dramatically exceeds the supply. A triage protocol is a set of guidelines to determine the allocation of limited medical resources during such an emergency. The principle of triage is to save as many lives as possible by prioritizing emergency treatment according to criteria often including the person's chance of survival or life expectancy. For example, under a triage protocol, it could be considered justifiable to remove an older, frailer patient from a ventilator in order to save a younger patient. When the priority of patients can't be made based on medical need, some triage protocols determine treatment by first come, first served, or lottery system. So Sarah, for your latest article for TVO.org, you looked into Ontario's triage protocol during the pandemic. What have you found?
So I've been following this issue for several months now, and as soon as I heard people talking about the idea that eventually care might have to be rationed, I wanted to know basically what the disability community was saying about it. I have a disability myself. I use a wheelchair, as you can probably see. And I do know that people with disabilities can face a lot of discrimination in the medical system. So I wanted to make sure that whatever protocol we were using wasn't discriminatory. What I found was the protocol's been developed over several drafts, and especially in the earlier drafts, there were some criteria that people would have been excluded from treatment that disability advocates did think were discriminatory. And then the other main concern people had was that the protocol wasn't made public for a long time, and it still hasn't fully been made public and hasn't fully been adopted, so there's a lot of confusion around it. So it is important to note that in response to feedback, the bioethics table did limit the use of the clinical frailty scale, so it's not used as much as it would have been otherwise. It is still one tool that is used for triaging, but the protocol has been revised to try to incorporate more of an equity and human rights framework. So there are still issues that the disability advocates have with this protocol, and they're still very concerned, but the new version of the protocol has taken their feedback into account. Whether that's going to be the final version of the protocol or whether that's going to be the version that everybody uses remains to be seen, but there has been some movement on these issues.
So as you mentioned, one of the criticisms from advocates is that the protocol wasn't made public by government. Let's talk about the other criticisms. I understand one that was mentioned in our show earlier this week, and we're talking about the clinical frailty scale. What is that, and how does that come into play when we talk about the triage protocol?
So the clinical frailty scale is a tool to use to assess frailty in older patients. So what that does is it measures a patient's ability to perform certain life tasks independently. So one of the tasks, for example, is being able to get dressed by yourself. Another one is using the toilet by yourself. Another one is can the person manage their finances independently? The idea is the fewer activities you can do by yourself, the more frail you're likely to be. This wasn't necessarily developed as a triage measure. It was developed, in fact, to figure out what kinds of care older patients might need. But it has been used as a triage measure, especially in older people. What the advocates were concerned about with this measure is, especially for people with disabilities, we might score differently on the test, even at baseline, than we would when we're in the hospital. It might have nothing to do with our medical prognosis of COVID at all. Like, for example, I've always needed help to get dressed. I've never been able to do that by myself. I likely never will be able to do that by myself. Um, does that have anything to do with my life expectancy as a 32-year-old woman? It's doubtful. And this measure has never been validated in younger patients.
I want to look at a certain ICU situation. Who would be deciding whether a patient receives treatment or not?
It would be doctors, and ideally it would be doctors in consultation with the family. So, for example, if a family member or a patient or family, so if a patient is conscious and can make their own decisions, and they know, for example, that they don't want to be on a ventilator, or their family member knows that they wouldn't want to be on a ventilator, they can hopefully tell the doctor that. But when it comes to people who do want critical care and there is not enough there to allocate it, then that's when doctors will be making the decision of who to exclude.
Is there an appeal process at all if a patient or a family member thinks that the treatment that they're receiving is not adequate enough?
It seems as though if there is one, it's fairly limited.
Now, what are we talking about when we talk about the conversations with government about the delay in implementing this policy?
So, I mean, it hasn't needed to be implemented just yet anyway. Like, we haven't been at a surge capacity, but there has been a delay in making it public. And even the bioethics table, who did write the protocol, all the versions of the protocol, and pretty much all the organizations who consulted on the protocol, they've all said, and everyone on the agenda panel that happened this week said, these protocols need to be made public. The public has a right to know what sorts of decisions doctors will be making.
When we talk about pushback, you had mentioned a little bit from disability advocates, but are we hearing anything from the opposition?
I've heard very little. I think I've seen possibly one comment from an opposition politician about this. And I do think that the reason for that is disability politics aren't necessarily partisan in the ways that we might think of some other equity issues being partisan. And in some ways that can be good because there can be more cooperation between parties on certain measures or certain policies. But I do think that there is a political consensus, pretty much, that people with disabilities might just be more vulnerable anyway, or we are more likely to die from the virus, and there's nothing that can or should be done about that.
Now, maybe the question is then, how does the triage protocol apply to patients without COVID-19? Does it?
It will apply to all patients.
Mm-hmm.
And I've read a couple of different drafts of the protocol, and they all have like fairly granular charts that basically say, this is when these patients will be excluded, this is when these patients will be excluded. And it goes through a whole bunch of different conditions. So like burns, for example, here's the conditions where we'll treat somebody with this percentage of burns. Here's the conditions where we won't. Heart attacks, strokes, major traumas like car accidents. So I think when people think of these triage decisions, they think of their own personal risks from getting COVID. And they think, oh, well, I've been mostly safe, so probably like this won't happen to me. But if the hospitals are in a surge or a crisis moment, and you walk across the street and get hit by a car, you are still at risk of being triaged out, depending on your condition. So I think it is an issue that everybody should care about because it does impact everybody.
One thing that you had mentioned was the term vulnerability. At the beginning of this pandemic, the directive from this government was to protect the vulnerable. Do you think that message has gotten through, or do you think that it helps at all?
I think it was well intentioned. I think I've noticed an evolution, and it's concerning to me because I believe in the beginning of the pandemic, it was all, everybody was like, yes, let's band together to protect the vulnerable. And then now it seems more, let's exclude the vulnerable so that I can go back to my life. And there's a lot of issues with this. And the main one is you don't know if you're vulnerable or not. like there's so little that we know about this virus anyway, and a lot of people have comorbidities or conditions and might not even know it. If you think that you are healthy and you have no risk of dying from this virus, I would ask you, have you checked your blood pressure recently? You don't know if it's high.
Mm-hmm.
Have you looked into like any other of these factors? Like anybody can be vulnerable, and in a surge situation where there's little capacity in hospitals, everyone is vulnerable because lack of trained staff will mean that a lot of people won't be saved who could have been because people are burnt out and they're not able to provide the same care to patients that they would.
Sarah, I want to thank you so much for coming on our show tonight and sharing a very important story. That is Sarah Trick, our Ontario Hub's editor. Thank you again.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.